Hello and welcome everybody. I am Dr. Santosh Kumar Sharma, Assistant Professor in Department of Anesthesia at BRD Medical College, Gorakhpur. And today we'll be discussing about ultrasound of shoulder joint. This is the first part of my presentation. I bring greetings from Gorakhpur. This is the medical college where I work. And my learning objectives will be to discuss about the normal anatomy and to know the tendon orientation specially. Then I'll be discussing about the shoulder ultrasound examination technique in detail, which will incorporate the patient position, the transducer placement, as well as orientation. Then we'll discuss about the normal sono-anatomy of the important structures, especially the cuff, rotator cuffs. Then we'll discuss few common pathologies and how to identify them in sonograph. All images and videos used in this presentation are my original work. Now this is the rotator cuff and it has basically the four muscles, the supraspinatus, and the orientation, as you can see, is oblique. It comes from the supraspinatus fossa and inserts into the greater tuberosity. Then we have the subscapularis, which runs from the scapula and it inserts into the lesser tuberosity, and the orientation is horizontal. Then we have the infraspinatus, which is basically the running along the obliquely from the posterior part of the scapula and inserts into the greater tuberosity. Then we have the teres minor, again same orientation, and we have another tendon which is not a part of the rotator cuff, but it is sometimes called the fifth rotator cuff, and that is the bicipital tendon, long head, which runs initially in longitudinal axis and then takes a sharp turn and becomes intra-articular. So these muscles and tendons will be discussed under ultrasonography. Then we have an important ligament which is called the coracohumeral ligament, which is runs from the coracoid and inserts into the humeral head. Now, what are the indications for ultrasound of the shoulder joint? Basically, it can be divided into two parts. One is the diagnostic and the other one is the interventional. And in diagnostic, most important comprises of the tendon and muscles or the rotator cuffs, and it deals with basically the tears, the ruptures, the dislocations, the tendinitis, the tendinosis, and the tenosynovitis. Apart from the rotator cuff, the non-rotator cuff pathology includes the bursal pathology, which can be thickening enlargement, then the bony and joint pathology, which can deal with effusions, osteophytes, degenerative changes, loose bodies, and the nerve pathology, especially of the subscapular nerve, which can get entrapped, or there can be neuralgia of these nerves. Then we have the interventions, the commonest being the subarachnoid subdeltoid bursa injection, followed by the glenohumeral joint injection, especially posterior approach is more commonly done under ultrasound guidance. Then we have bicipital injection, acromioclavicular injection, and we can also do aspiration of the joint cyst and calcium deposit. So why ultrasound? What are the advantages? The first and foremost is that is very accurate, and its accuracy is almost equal to the MRI, especially for the full thickness tears, and it approaches almost 96%, while partial thickness also it is 94%. And it is very helpful, and patients will obviously prefer ultrasound over an MRI because it's so easy and can be done bedside. Then obviously it's less expensive, and the important part is that it's dynamic and it can be repeated uh, n number of times. Coming to preparation and ergonomics, the ultrasound you need must be of high resolution. The probe should be of high frequency linear probe. The patient should sit on a revolving chair. The examiner is basically sits in front, or he can also stand from behind, but all the time he faces the ultrasound screen, and the depth of the screen is set at 4 to 5 centimeters. Now, for ultrasound of shoulder, you need a scanning protocol. And what is that protocol? It's basically to assess the shoulder comprehensively and you do not forget anything. So, you have a system developed which is basically you start from the long head of biceps tendon, then move on to the subscapularis tendon, then you have the supraspinatus tendon, then you have the acromioclavicular joint, followed by an impingement evaluation, and finally the infraspinatus teres minor, the posterior glenohumeral joint, the posterior labrum, and the suprascapular nerve. Now, a thing to be noted here is that all the tendons will be evaluated in two axes at least, which is basically the long axis and the short axis, so that no pathology is missed. Another important thing to understand here is anisotropy. So, what is anisotropy? Normally, when the ultrasound probe is placed on a tendon at 90 degrees, it appears fibrillar, and this is because tendons are highly reflective. Now, any little manipulation of the probe will lead to a hypoechoic structure which is different from the normal and will be confused as a pathology, and this is what is called anisotropy. So, in order to avoid this artifact, we should always take multiple views and align the probe perpendicular to the structure, and also we compare from the contralateral side to get diagnostic conclusions. Now let's move on to the first part, which is basically scan of the anterior shoulder, and here we'll be dealing with the long head of biceps tendon and the subscapularis tendon. So let's discuss the technique. In this, we start with the short axis scan of bicipital tendon, and this will be done at four levels. So, what are those levels? First, we scan directly in between the greater and lesser tuberosity, that is where the tendon lies in the groove. Then we slide the probe little downward to check all through the tendon, and then we move further up into the intra-articular part, and then again slide down to see the myotendinous junction of the bicipital tendon. This is the normal position of the patient, and the patient basically sits on a stool with his arm adducted to his chest. The elbow is flexed at 90 degrees and the hand is held in neutral position, which is basically supination, and the palm is facing up. After having done so, we visualize the bicipital groove and palpate it, and then put the probe horizontally, which becomes short axis for the tendon. And once this is done, we orient the probe so that the tendon is visible in the center. So, how does that tendon look in the center? Basically, one can see in the first figure, which is the superior scan with a deep bicipital groove, and as the arrow is pointing towards that bicipital groove, then we have the lesser tuberosity on the right side of the screen and the greater tuberosity on the left side of the screen, which is basically lateral, and on the medial side is the subscapularis muscle. You may notice that because of anisotropy, the subscapularis appears hypoechoic, but on further evaluation, we concluded that it is normal. Now, one other tip is basically to avoid anisotropy, the angle of the transducer is placed superiorly to eliminate the echogenicity of the tendon. Now, in the next is the inferior scan, where you can see that the bicipital groove has flattened out. And also pointed here is the transverse humeral ligament, which runs over the bicipital tendon. Now, coming to next picture, where the probe has been moved high up into the rotator interval, which is basically the space between the supraspinatus and the subscapularis. And here we will visualize the intra-articular part of biceps tendon. Shown here by arrow is the bicipital tendon in the center, and then we have the coracohumeral ligaments running superiorly above it in the intra-articular part, and the superior glenohumeral ligament running inferiorly. These two provide additional support and prevent subluxation of the bicipital tendon. Then we have the muscles medially, the subscapularis and the suprascapularis on the lateral side. When we scan down, what we find is that the bicipital tendon has transformed into this is basically the myotendinous junction, where the long head and short head have changed into a tendon, and there you can see the pectoralis major tendon also, which gives another support. Then this is a short video where we will be scanning the bicipital tendon, and we'll move from the bicipital groove into the intra-articular part. So let's see. This is the probe placement, horizontally placed probe, and then as we scan we can see the bicipital tendon, and then we slide the probe up and we enter into the intra-articular part of the bicipital tendon as seen in the center. Then this is repeat scan where we go down from the intra-articular part to the myotendinous junction below, and here again the probe will be slid down and see what happens. This is basically the bicipital tendon in the center, and then we are sliding the probe down. Again we can see the bicipital tendon in the bicipital groove, and we follow it down, and now it is becoming, this has become the myotendinous junction, and we can see the white hyperechoic line, which is the pectoralis major tendon. Coming to the second part, which is scanning along the long axis of the bicipital tendon as shown in the picture, then the position remains same, and the only thing which changes is the probe orientation, which has been rotated by 90 degrees to become vertical. And once we have done so, what we see is the humeral head and the humeral shaft, and the bicipital tendon runs longitudinally over it, and that's about the long head of biceps tendon in long axis. Now coming to the subscapularis tendon, this again we start with the long axis scan of subscapularis. Notice here that what was short axis for the bicipital tendon has now become long axis for the subscapularis, because the muscle is oriented in the horizontal manner. The only change in position here is that now the arm has been externally rotated. Rest all remains same as before, and as shown in the picture, the probe is oriented horizontally, which is long axis for the muscle. Here another tip is that once we have found the bicipital groove in neutral position, then just rotating the externally brings the subscapularis into picture. So this is how it is done. Initially you can see the bicipital tendon on the left side or the lateral side of the screen, and on the medial side is the subscapularis, and once you externally rotate, the subscapularis bulk comes into picture. This is a small video of how the muscle is scanned, and here we have put the probe in horizontal manner just along the bicipital tendon, and then on scanning we can see that whole length of the muscle is seen, and we can appreciate the fibrillar structure of the muscle. Moving on to the short axis scan of subscapularis, here the probe orientation becomes 90 degree and rest all remain same. So we have rotated the probe and now it is in short axis for the muscle and the probe has become vertical. Again, what we see in this is basically a heterogeneous echogenicity of the subscapularis, and mind you, this is normal for this muscle. This is no pathology, and this is because this muscle is a multi-pinate muscle, and we do not expect any pathology because the white hyperechogenicity is because of the tendons, and that is interspersed with the muscle fibers as shown by the arrow. After this is a small video again of the short axis view of the subscapularis, and this is how it looks while scanning. Please do appreciate that there is no pathology in this subscapularis, and it's basically normal. Moving on to the next part, which is basically assessment of the coracohumeral ligament, and then we will do a dynamic scan of the biceps tendon. So how do we do a sono-anatomy of the coracohumeral ligament? We place the probe a little medial from what we were scanning for the subscapularis, and the coracoid process comes into picture, and then the probe is again in horizontal orientation, and what we see now is the subscapularis muscle originating and coming out below the coracoid process as shown in the picture. And here I would like to stress upon that coracoid process and subscapularis must be viewed because you can find anteromedial or subcoracoid impingement syndrome where the subscapularis tendon impinges over the tip of the coracoid when the arm is flexed forward and in maximal internal rotation. Also, one can find some scapularis cyst and bursa in some cases. One must also understand that the proximal part of coracohumeral ligament becomes hypoechoic and thickened in case of adhesive capsulitis, and this is what is the coracohumeral ligament originates from here. The white hyperechoic line is the coracohumeral ligament. Moving on to a short video, here we have placed the probe horizontally, and this is how we find the subscapularis, the coracoid process, and the coracohumeral ligament. Moving on to a dynamic scan for the subluxation of the biceps tendon. This is important because bicipital tendon may get subluxated because of pathology, and it usually does so on the medial side. To test that, what we do is basically we scan the biceps in neutral position with the arm adducted, and then we externally rotate it, the arm, and keep doing so to see if the bicipital tendon is holding in the bicipital groove or not. So what we do is here in a short video we'll be demonstrating this, and this is the movement of the arm which is seen in the ultrasound. So once you have identified this, that this is the sono-anatomy picture, and we can very well appreciate that the bicipital tendon doesn't come out of its groove and it's normal. This completes the first part of the presentation, and in the next part we'll be dealing with the other structures, which is basically the supraspinatus, the infraspinatus teres minor, the posterior glenohumeral joint, and the acromioclavicular joint. Thank you very much. We at BRD are very much committed to relief from acute as well as chronic pain. This is my YouTube channel by the name Santosh Tata 1976, and it is deals with all types of blocks, be it PNS guided, ultrasound guided, C-arm guided, LOR techniques, chronic pain blocks. Please do like and subscribe. Thank you very much. This is again, I'm an artist too, and you can visit my Facebook page at the rate Apna Creations, and like and subscribe to this page.